I'm Tamara Ugolini here with Rebel News, and in today's report, I'm going to feature a scientist who has dug into a health issue that is perhaps even more controversial than COVID-19, if you can believe it. We are going to be discussing Lyme disease, which was brought to my attention more recently when I dug into Ontario's Chief Medical Officer of Health, that's Dr. Kieran Moore, and his connection with COVID injectable manufacturer Pfizer, of which Dr. Moore sits on their North American Lyme Disease Strategy Board. Those reports have already been published, and I'm continuing to follow that beat, so I will link to them in the written component of this report. But in this specific report, we will be discussing Lyme disease and one of its less widely known afflictions, Morgellons disease. So joining me now to discuss not only Lyme, but also one of its extremely taboo symptoms is scientist Marianne Middelveen. She is a Canadian microbiologist and both principal author and co-author on a number of peer-reviewed studies. Here's what she has to say.
Lyme disease is a bacterial infection caused by a group of organisms that are spiral-shaped in culture. So these are called spirochetes, and they are from the genus Borrelia, which is transmitted by Borrelia are transmitted by arthropod vectors. So the Lyme disease type organism is transmitted by exotid ticks or hard-bodied ticks. And then the relapsing fever Borrelia are transmitted by argacid ticks, which are soft-bodied ticks. I got into research for Lyme disease in 2010. I started researching it, and that was after I had discovered I had Lyme disease myself. I'd been bitten by a tick, and I had a bullseye rash, and I ran into the same problem that most Canadians do. I could not find somebody to recognize and treat the Lyme disease. So that sort of triggered my investigation into Lyme disease. I like detecting microorganisms, and I don't have Morgellons myself, but I heard about this strange skin condition, and then I went out for dinner with a veterinarian that I do microbiology for, and he mentioned that cattle have a strange infection that's spirochetal, and that where there's little lesions formed that have unusual filaments. And so I knew something about Morgellons being similar to that, and I thought it would be interesting to compare the two skin conditions. So that's basically how I got into it. But because I was involved with this Morgellons research, I was able to, I started culturing, which is growing in liquid, some of these microorganisms. So I began culturing, and then I also started looking at tissues and doing very special molecular stains so that I could visualize the microorganisms. And that enabled me to do it on some of my own tissue. And so I was able to prove conclusively that I had the disease. I did have my blood tested in Germany, and they had a different kind of test. It also looks for the immune response, but it looks for a cellular immune response rather than an antibody-mediated immune response. So it's slightly different, and I was positive on that test, but in Canada, it didn't matter what test I had done, it was not going to be recognized. So I was pretty much spitting in the wind trying to prove I had Lyme disease. And it didn't matter what evidence I was able to pull out of the hat. It was just not going to be accepted here in Canada unless I reacted in a positive manner to that defective two-tiered test that we do.
What has been some of the things that are most polarizing on the topic of Lyme disease and how it affects Canadians in terms of research and identification?
Okay, the topic of Lyme disease is polarized, and there's 2 points of view. One point of view has a very rigid and a and narrowly defined case definition. And so in that point of view, they have test requirements that are very stringent, and most people who have Lyme disease just can't pass that testing protocol to be considered a positive. And the other point of view has a more lenient test requirement and interpretation. So the other part of the controversy stems from the fact that the one side believes that persistent infection despite antibiotics does not exist. They believe that between 2 and 4 weeks of antibiotics are sufficient for treating Lyme disease. And the other point of view states that there's a lot of strong scientific evidence in peer-reviewed literature that shows that persistent infection despite antibiotics does exist, and it's been shown in animal models, including rhesus macaques, which are apes, and it's also been shown in humans.
What are some of the key characteristics to look out for in a Lyme infection, and especially for those more long haul cases?
Well, each person can be affected with Lyme disease in a unique individual way, and it depends on what tissues that spirochete is infecting. So a lot of the symptoms tend to be a lot like they would be for long-term syphilis. So a lot of neurological problems, cardiac problems, joint problems. Those are probably the more common ones. So a lot of patients describe brain fog and very sore joints and fatigue. So that's a problem too, because this sort of symptom is very generalized and could be present in a lot of different diseases. So there many different conditions can cause that same sort of symptom.
What is specific to Morgellons disease in terms of how you identify it and what these patients are suffering? I know you had a paper published on PubMed titled "The History of Morgellons Disease from Delusion to Definition." What was the basis of that paper?
Patients that have Morgellons have these little skin lesions, and they can be, well, some of them can be quite big, but in general, they're these excoriations and or ulcerations. And when you look at them under a microscope, you'll see projecting or embedded fibers. And these little fibers, they in a way resemble textile fibers, so it's very difficult to differentiate them. But you'll see them under 100x microscopy, and that's really what defines a Morgellons case. And then in that thickened callus, you'll see embedded fibers. So these things are not superficial, they're embedded right into the skin. And then after a while, the skin, that callus separates from the underlying dermis. So the dermis are the lower layers of the epithelial tissue. And then the upper layers are called is the epidermis. So that epidermal layer will separate off of the dermis, and then it can, sometimes patients pick it off or it can fall off. And then you generally see some of those little filaments coming in from the side. But the calluses have a lot of the embedded fibers in them. So once that separates, we can fix it, and we can make slides, prepare slides so that we can see that tissue under the microscope. And it's when we do that we can actually see spirochetal infection in that tissue.
So just to make sure that I'm understanding, because this seems just such a weird affliction to have to deal with. So this was originally coined as a delusion.
Right.
Based on this paper, The History of Morgellons. So how were these patients being treated prior to this microscopic investigation of what was going on here?
Well, before before the association with Borrelia and spirochetal infection was known, they were treated with antipsychotic medication. And the doctors believed that these patients dug the holes in themselves and then implanted textile fibers that they'd find lying around their house or from stores when they they went to clothes shopping, that they believed patients would pick out all these little fibers and then actually embed them into their own skin. And then they believed that the patients were delusional in believing that the skin had produced these filaments. And that is totally incorrect. The filaments are produced by the human body, and they're hair-like structures. So they're generally collagen and keratin, and they're product of the human body.
Yeah. And so, how did you find out that they actually grow from and within the skin?
When I do that sectioning of the skin, when I take the callus and then I have it sectioned into little tiny thin microscopic slices, I can look at it under the microscope and I can see the point of origin. So they tend to originate either from the dermis or the epidermis. And you can see, a lot of times you can see the base of attachment on the basal cell layer, but also they can come from a hair follicle, from within a hair follicle. So something just goes awry, and the proteins, the keratin and collagen, are just expressed in an abnormal manner.
So these papers that you've written, the Morgellons disease goes back to 2016, and this other one, the history of Morgellons disease, goes back to 2018. Fast forward now to 2022, how are patients suffering from this affliction being treated?
Well, for those doctors with the point of view that it's delusional, they still are treated with antipsychotic medications. So, and then there's those doctors who believe the new evidence and they're treating it with antibiotics or, other supportive therapies.
I had been contacted by a patient, and he really was trying to disseminate this information to me and also to the Canadian public, that there are a lot of people really suffering with this disease that are being gaslit into being psychiatric patients. And he referenced the CDC study. I had another scientist look it over and just get some feedback from him as well. And he said that it just reeked of bad science. Are you familiar with this study that I'm referring to? And what would be your thoughts on it?
I am familiar with it, and I did a PowerPoint presentation on that very topic that you can access through the Charles E. Holman website. But, in general, they chose their patient selection was faulty. So they didn't require the presence of those filaments under unbroken skin the way we would. So right off the bat, their patient selection was faulty. And then their methods for looking at Borrelia burgdorferi infection stem back to that controversial Lyme testing. So they used that insensitive test in order to try to find infection in these patients. And of course, those tests are not sensitive enough, and they're not going to pick up every case.
What would your message be, or your hope be, moving forward, as the science evolves and as more people become familiar with and discuss this, not only Lyme disease, but maybe the symptoms that go in hand with it, like Morgellons disease? What would you like to see change or be approached differently?
First of all, if doctors would actually look at some of these lesions and not just dismiss the patients and call them delusional, that would help. Because for something to be called delusional, it requires a false belief. And if there's a true observation, then that's obviously not a delusion. So all they need to do is get off their butts, get their microscope out and look at the tissue. So secondly, I'd like to see a more liberal or more lenient testing requirement for Lyme disease. And then if they used a different test protocol, they'd find out that a lot of these patients have detectable Lyme disease.
What would that testing protocol look like compared to what we see kind of being implemented as the standard in Canada?
Well, in Canada, we do a screening test followed by a more sensitive test called the Western Blot. And this is a test that just looks for the immune response in the patient. So it looks for antibodies. And if you don't produce enough antibodies, then you're considered not to have it. So you have to react to so many of the different cellular components. You have to react to 5 out of 10, for example. And then the screening test is very insensitive. So I'd like to see them do away with the screening test and go directly to the Western Blot and not require so many different antigens to be present. The second thing, they should look for, accept different methodologies other than just looking for an immune response. For example, if they did direct detection methods, they'd be looking for the microorganism itself. So if you see the microorganism in that tissue and identify it from that tissue, then that should be proof of infection.
Now, for any patients, people who are suffering with either of the, this disease or some of its other symptoms or co-infections, where can they go to learn more? How can they advocate for themselves in wake of this kind of divide and controversy around Lyme disease and its co-infections?
Probably the best place for for people in Canada to go would be to Can Lyme. The Can Lyme website is an excellent resource for information. And I believe that they can give people, let them know of different options of where they might get treated. So that would be my recommendation for people in Canada. For people in the US, I would have them go to the Charles E. Holman's website. They will also help Canadian patients too. And then International Lyme and Associated Disease Society, or ILADS, they can also do patient referrals. So I would go to any of those sites. And also LymeDisease.org is a good source of information.
Great. Well, thanks so much for joining me, Marianne. I appreciate your take and insights on the topic.
Thank you so much for having me.
If the last 2 years have shown us anything, with unprecedented gaslighting seen on the general population and anyone critical of the mainstream narrative, I speculate that there are similarities here on how Lyme disease, its co-infections, and symptoms have been addressed. And medicating people psychologically for physical ailments that can be proven with more clinical investigation seems like a great way for pharma to generate an endless customer base rather than seek unprofitable cures. For Rebel News, I'm Tamara Ugolini. At the Rebel News store, you can find nifty designs like the one I'm featuring here, Rebel with a Cause, and we have a bunch of new designs just in time for summer. At rebelnewsstore.com, you can find all of our new designs, and we also offer free global shipping. For a limited time, using code SUMMER, you can buy 2 unisex t-shirts and get the 3rd free. Head on over to rebelnewsstore.com and check it out for yourself.